we felt a little bad about was having to end the HBIA program. And we were under the impression that we would be able to have those folks use the state-based exchange that's planning to be set up at the end of this year. And at a certain point, we realized that I think either in the reconciliation bill or in another way, the federal government said, no, you cannot, even the state-based exchange will not be able to include undocumented. So at that point, we were like, uh-oh, we have to figure something else out for the undocumented. And we at that point, we said, well, we also in the House, we have a process where we really include all our members in budget making. We share all the details that we can with them, and we ask for their opinions on what's important to you, what would you like to fund, what do you want to see, were there things taken out of the budget that you want to put back in? Because as you know, the budgets are pretty much the same. 95% of them are really the same every year. It's like, we're playing around the edges, but the edges on a $55 billion budget are very important to our local organizations. So what we heard back was concerns about funding more funds for free charitable clinics. That the governor had cut back a little bit, and so we added that up to what it had been the year before. And then, many of us knew about federally qualified health centers and wanted to make sure that, because where are people going to go if they don't have insurance? They're going to go to Cook County Hospital, Kathy, and they're going to go to the federally qualified health center. So we wanted to, as much as we could, increase the funds for those organizations. And also we wanted to make sure that we also took care of the safety nets. So those were kind of our ways to address the problem of losing the HBIA program.
Great. And I'm glad you brought up the HBIA program, because obviously that was what got a lot of the headlines. You and your colleagues did decide to keep in place the program for the undocumented seniors, 65 years and older. What was the decision behind that, to keep that program in place?
Yeah. So that was interesting, because at one point in our budget groups, our budget meetings, HBIS was on the table. And the House was like, what? I don't think we can do that. I don't think our members will allow us to do that right now. And we looked to see in the reconciliation bill when the effective date would be, or the implementation date would be for not funding the ACA expansion population at 90% if we were serving any undocumented. And it looked like that wasn't going to happen until next fiscal year. So we felt like there wasn't any urgency to get rid of HBIS this year. Also, it's, it costs a third of what HBIA costs. It's like $110 million, which is still, significant dollars, but it costs a lot less, and actually the costs are going down in that program. So, I think we've closed the door on most of these programs. So, the costs are going down, and we just felt like that was a program we just felt it was important to keep this year.
Okay. So it sounds like it's something that you and your colleagues are going to be monitoring. Maybe we're having a different conversation next fiscal year.
Yes, next fiscal year will be another discussion.
Definitely. Great. Dave, I want to go over to you. You kind of touched on in your opening, but just kind of, how are your members coming out with this budget package? What are some of the main pieces there for you?
Yeah, let me continue the conversation on the HIA program, because the rules are being considered a day-by-day cards when we make the program. And IHA has offered comments to suggest to HFS to have continuity of care provision to follow through with some of this important care, because there are hundreds of appointments that are in place right now, and I think the later point to Cook County Health, over 160 of our hospitals, these residencies, these immigrant residencies presented at over 160 of our hospitals, but half of those inpatient days were at Cook County Hospital. So those costs are going to be absorbed. And the problem is that these patients are still going to seek care, but they're going to be sicker, and it's going to actually be more expensive. So there was no best option for the General Assembly with respect to this program, but it's really unfortunate what's happened here, and the costs are going to even be more, especially for Cook County Hospital, where half of these inpatient days were served. But with respect to the budget, yeah, good news on the budget. The General Assembly did not overreact to the chaos in Washington. They kept Medicaid rates the same, they kept eligibility the same, and they were able to restore some of the grant funding that the General Assembly has included for our safety net hospitals for the past several years, over $120 million that's each needed. In fact, really critical to preserve services in underserved communities like the Roseland community.
Mm-hmm. John, I want to go over to you. Before we talk about the budget, I was curious, do you have any of your members, is the end of the HBIA program going to have any sort of impact on your members or some of the patients that you serve?
Yeah, absolutely. We do have members that provide and target or tailor their services for addiction and mental health treatment in that area, and then a number of providers that do so across the board. It was not the lead priority for the association this year. We work alongside our partners in the other fields to do so.
Okay. And then obviously you kind of touched already in the beginning, but is there any other big highlights out of the budget for behavioral health that you'd like to talk about that, really are going to affect the field?
Yeah, I did touch on the increase that we saw, reinstatement to funding, about $36 million in substance use funding. And that goes towards the non-Medicaid population, which is going to be incredibly important this upcoming year, as we've seen from Washington, all of the changes that may be forthcoming there, the loss of, well, I'm not going to get ahead of this. But that will also provide a small rate increase of 2% for our provider members. The 988, we were looking to have some kind of tax on the phone system, and the $45 million obviously will address most of that. In terms of the other areas, I don't know if you had a separate question on this, but the BIP actually included some language that we want to monitor closely. There were 2 funds related to youth prevention that had been folded into GRF or other funding sources, and so we represent the entire continuum of behavioral health, so it's prevention, treatment, recovery, harm reduction, in all of its forms. And prevention is obviously key in preventing any of the following services from being necessary. So prevention is very key. We want to keep an eye on that.
Definitely. Now, Garth, I want to go over to you. Obviously, one of the main non-budget pieces of legislation that passed this year was the pharmacy benefit managers reform. That's something that I remember talking to you for years about some of the steps that are happening. Obviously, Governor Roy put his, force behind this one this year, and it passed unanimously in the General Assembly. Chris has already pledged to sign it. Can you tell us a little bit about the work that went into this legislation and just, some of the negotiations on this?
Well, it's years of advocacy. For most of the people on this panel that know me have known that it barely 30 seconds after I said hello, I'm talking about how PBMs need to be reformed. And but this goes to the whole aspect of advocacy in motion. That's what I told my members, is that your voices were finally heard clearly through this process. And it takes, because it's very complex. It is not an easy process to understand, and when we have to pull back all the different layers of manipulation to show everyone what is really going on in this complex onion that is PBMs. But we've worked with the state and the General Assembly in a number of ways of trying to address this, primarily since 2019 with Leader Harris and Deputy Governor Menard, and just keep building and pulling away each of those threads. And now I think we've got a tremendous aspect of being able to fundamentally help lower costs for patients, bring in a lot more transparency so the state can see everything, and then try to slow the expansion of pharmacy deserts. And that's the biggest aspect of it. But we're not going to stop all of them. I mean, we just saw Walgreens announce there's going to be another 10 closures of stores here just in Illinois. And so, there's still parts of PBM reimbursement form we still need to address when it comes to reimbursements and reimbursement parity. So those are things that we still need to continue, but this level of movement that the governor put his force behind, and the negotiations on it were with all parties, and as always, it's very tough. It can be very heated. As we, we're saying, this is what we're seeing for patients. PBMs are like, hold on. And it's just, and it's always so hard when we're having to pull all this data together to show what's going on. And we're glad to see the state of Illinois really paying attention and listening to what's been going on in healthcare, going on with the patients, how the patients been manipulated. And I'm glad that employers are starting to listen. They still need to listen a little more, especially from union plans and how they've been manipulated through this process. So there's still a lot of ways to go. I think this is a huge step forward. And I don't think everyone understands how big of a step Illinois took in getting into the front of the line and saying, we're going to lead on this issue. I can't think of another state right now that has the transparency suite of provisions as Illinois does. Illinois is now ahead of the game in showing what can be done, how the state can be utilized to help lower costs, and really look at the true cost of healthcare.
And obviously quite a lot of provisions, a lot of things in that package. What are some of the things in there you think are going to have most impact? What do you think are the most important provisions in that legislation?
Elimination of spread pricing. Really stop that main manipulation. And that's going to impact commercial plans all the way down to Medicaid. So Medicaid's going to see a lot of lower costs and actually movement of dollars that should have went to the pharmacies. And hopefully we're also going to see the end of patient steering. And so patients won't have to be forced to use mail order pharmacies or specialty pharmacies. And as part of that steering provision, the PBMs can't pay themselves better than they pay anyone else in the network. And that may not sound like a major provision out here, but it's a huge aspect of trying to level the playing field. And just bringing access, because patients want to use the pharmacist in their community, and they have not been able to because of how we design healthcare plans being so employer-focused tied to their jobs. They've just had to go to where they're told, and now patients have that right back to them.
I think, Garth, I want to say with you for one more. Obviously, the governor has already said he's planning to sign the legislation. What's next? What does the implementation of this look like? And when might we start seeing some of the effect of this?
As I've talked with our members, just saying, just because it starts on January 1, that's when the contract changes. So, we'll see some plans, but I really think it's going to be that first half of the year into the latter half of next year where we see a lot of those contract provisions truly starting to flip over as they become compliant. One of the things I think that's really great in this bill was there is a market analysis, a complete market analysis that DOI has to do on the 3 top PBMs, and that has to be done starting in 2026. So Tennessee had just done a report late last year, earlier this year on Express Scripts, and showed how Express Scripts completely ignored the law. Well, doing a market analysis at the beginning of the implementation of this bill shows that the PBMs have to start complying right away. So we may see some sooner transitions with the provisions of the bill because of that market analysis, or DOIs hold them accountable.
Judd, I want to go over to you. Another piece of legislation that Pritzker discussed during his budget address in February was the elimination of prior authorization for some outpatient hospitalization services and coverage for some transportation services. And I wonder if you could just talk a little bit about that legislation, which did pass this year, and just kind of what the impact of that is going to be.
Yeah, absolutely. So just to kind of set the stage, obviously last session we saw mental health inpatient prior authorization prohibition being implemented, but there was not a prohibition on mental health outpatient or substance use disorder outpatient. And so we had all worked together in the field to try to establish a broader prohibition for both mental health and substance use disorders. And we succeeded on the mental health side. And so we will see a dramatic change there, the reduction in prior authorization for mental health outpatient now as well as inpatient. Back in 2018, we were able to push for SUD residential level treatment prior authorization prohibition. That wasn't quite as comprehensive as this new and improved legislation. So we had requested that everything be brought up to date, so to speak, and included in the new bill. We were unsuccessful in that regard. We did see some updates to the 2018 legislation, but we did not succeed in including what is known as Addiction Society or American Society of Addiction Medicine Level 1 or outpatient level services included in the prior authorization prohibition. So that's something that we'd like to continue to press for to make an even playing field. Many of our members provide both mental health and substance use disorder services. This year, as of July 1st, the department is combining or integrating the Division of Mental Health and the Division of Substance Use Prevention and Recovery into the new Division of Behavioral Health and Recovery. So it made sense to really try to integrate that as much as possible and make it a level playing field, as well as level compliance measures across the field. You've got both the compliance efforts with respect to the provider, but then on the managed care and the plan side, they'll also have to be implementing different prior authorization prohibitions or utilization as they move forward, depending on whether it's SUD or mental health.
Excellent. And just kind of, Judge, what do you think this is going to mean for the patients in Illinois, those who, rely on these services?
Yes, the feedback that we got from the membership and on the use of prior authorization, and it continued even under the 2018 bill, was very frustrating trying to get patients in for treatment, particularly those in very dire need. Our members deal with some of the most vulnerable folks in terms of their situation, their demographic, their location, and so taking that off the table to get them into treatment as soon as possible is going to be a dramatic improvement in treatment.
Definitely. Dave, I want to go over to you. I want to follow up on the piece you talked about earlier, just kind of on some of the workforce initiatives, some of the effort. Can you just tell us a little bit more about how that legislation works, and just kind of the idea of how this is going to be able to help hospitals and providers in the state?
I appreciate that. And so, as I said, this has been the number one issue with our membership year in, year out for the past several years, coming out of COVID with retirements and recruitment and retention challenges. One example, this is working with Chairman Morgan and Susie Klobuchar-Hilton in the Senate, is fixing this broken licensure system that we've had in the state for decades. And again, you get back to the budget, it all comes back to money. And General Assembly for the past 2 years have put into the budget funds to update that system, to modernize that system. And we are starting to see more and more licenses go online through this new operation. But we're losing out in competition for highly paid providers because we're not quick enough to be able to offer those employment contracts because those licenses haven't been approved yet. So this has been a point of emphasis, especially with the licensure committees in both chambers, with Chairman Morgan. Actually, he presented to our board last year, very excited about that. It's probably the number one workforce issue with our membership, to be able to get those registered providers quicker. I mean, at one point it was taking 6 months to bring a nurse on to a hospital. So what happens, Ryan, it just catapults on itself, right? So if you can't find the providers, you can't staff the beds. So what happens is things stack up in the emergency department. And when things stack up in the emergency department, tempers start to flare, violence occurs, and that becomes a retention issue in of itself. So we want to look at a number of things. We also want to look at the pipeline. Again, the General Assembly has done some good work with community colleges to provide some funding for individuals to enter into the healthcare services. But can we talk to the nursing deans? Can we figure out how to expand that pipeline? Not only just nurses, but techs, respiratory therapists. It's across the entire board. And if you think about the hospitals, they employ 250,000 people in the state, some of the largest employers in the state. They generate another 250,000 jobs, over $120 billion in economic activity. We have to get this right for the economy of the state, not only for the patients we serve, but also for the state's economy.
And Dave, I want to stay with you for a moment because we'll talk about legislation. Yesterday, Governor Pritzker signed legislation related to hospital assessment. And I wonder if you could just talk a little bit about some of the changes there and kind of what that's going to mean for hospitals.
Yeah, happy to. And I think Leader Gable's been around for a long time. I mean, the hospital assessment is really what funds the majority of the Medicaid program in the state, right? Both for those hospitals that are dependent on the Medicaid program and those hospitals that the Medicaid program depends on. It's extremely important. And what we're talking about is a proposal that was filed with federal CMS back in December that would increase our assessment tax by over $1 billion and that would retrieve about $1.47 billion in increased reimbursements to hospitals. And if you look at the fact that the stimulus funds are gone, the tariffs, the economic uncertainty, there's not going to be a lot of direct increases for Medicaid in the future years. So the assessment is really one of the single best ways to increase reimbursement for our hospitals. And this thing has been pending since December, out yesterday, because that was going to allow our hospitals to provide the care they need, be reimbursed. I mean, the labor and drug costs since COVID have escalated. They're really driving the cost of health care, both drug costs and labor costs, and yet the rates are relatively flat in terms of the Medicaid reimbursement. Most of our hospitals lose money treating Medicaid patients. So the assessment is that one best way to address that. The Senate report that came out last night threatens that whole proposal because it sets as a May 1st date. It's an arbitrary date of May 1st for proposals that have been approved by CMS. Our proposal is going through the approval process right now. We think it should be approved. All it does is increase the tax. It doesn't do any other changes to the system. So we're very concerned right now about that proposal. But it also required the state legislation that you're speaking to right now that set the rates that for the 7 classes of the hospitals that are in the assessment. It's critical for our safety nets. If we can't get this assessment approved by CMS and enacted this year, financial pressures for our safety nets are at a point, really a breaking point. I think you heard that in the last few weeks of session. I think that's why the General Assembly found the funds to help our hospitals, but that's a short-term solution. We need to get the assessment approved in Washington, and that legislation was required in order to affect that.
Definitely. Leader Gabe, I want to move over to you, and there's a couple different ways we can go there, but speaking of things that Governor approved yesterday, he did sign the Medicaid omnibus. Your colleagues called it the leanest package in recent memory, specifically because of all this uncertainty at the federal level. I wonder if you could tell us a little bit about how the Medicaid working group came together this year and how the conversations were like towards this package, and just kind of what are some of the key takeaways from the legislation.
Sure, thank you. So this year, I was not chair of the Medicaid working group, but I was still on it, and I worked closely with Representative Moeller, and Sophia is here, our staff person on the Medicaid working group, which was fantastic. She did an amazing job. I know it was kind of strange because I'm used to spending a lot of money on Medicaid omnibus. 2 years ago, I think it was like, rate increase for you, one for you. I'm familiar with the Medicaid program, and I know how little it paid, and I know how much people needed a rate increase, and we were able to do it that year. So this year it's very lean. Let me see the number exactly.
Well, look, I know your colleague, Representative Moore, said it was less than $1 million for implementation. So.
Yeah, it is. Sorry, I lost the paperwork. It is, for this fiscal year, the cost is $719,000 gross and $359,500 net, which is zero. The annual gross next year is $938,000, and the annual net is $469,000. So years ago, when I used to be an advocate and try to get things in the Medicaid budget, they would tell me that anything under $1 million has no impact on the Medicaid budget. So this clearly has no impact on it. But where is that? Oh, but we do have quite a few items in the Medicaid budget this year. In the Medicaid omnibus, we had a few items that HFS put in themselves, that there were just some changes they wanted to make. But we also clarified things like making sure that in maternal health constituent came to me and had all these reports on how choline can help with better birth outcomes and healthier babies. And the cost was obviously under $1 million. So that was included. But also, we looked at things like some nursing home staffing ratios at the end. We made a few little changes to help some hospitals in contiguous counties be able to be counted as the same network, and just a number of smaller items that we were able to put in the omnibus. It was, but what's really important for us is the process, which you asked about. So the process has been that we take all the bills that really have an impact on Medicaid, and we put them all into the Medicaid working group, and then we go through them one by one. And we have not a lot of time on each of them, probably 15 minutes maybe, but people, the advocates come and speak about it, supporters speak about it, and then the department speaks about each bill. So it's a great process for training new people, which we're all about in the House. We had a lot of turnover as both House. Well, House probably has more turnover than the Senate, I would say. But so we had, I don't know, 10 members maybe from the House?
Oh, yeah, like 10.
12 members from the House who were interested in being on the Medicaid working group, and we included them all. The Senate, on the other hand, tends to have just 2 or 3 people, and normally we go through these bills together with the Senate and the House. And actually, the Senate President, I asked him, I said, "Are you going to join us this year? You know, I'd like to work with the Senate again." And he said, "Well, you have so many people." And I was like, "Yes." I said, "Yes, we like to have. We have a lot of interest in Medicaid in the House." And he felt that he wanted to do his bills just through the regular process. So, but at the end, we did have a couple senators that worked with us, though. And at the end, LG and I sit down and go through the whole list, and also with some of the staff on both sides. And we have the power to nix anything on the other's agenda, and we have the power to add anything that we want to add. So we did that. A few things were taken out, a few things were added in, and we had some discussion, and we had a good Medicaid omnibus. And then what we do at the end, which is kind of fun, is we take all the bills that we've reviewed and we go through them, and we say, okay, is this green, yellow, or red? Is it green? Go for sure. Is it yellow? We really love it, maybe, but there's a bigger cost this year on it, and we don't think we may be able to do it this year. And then red is, no. So we went through that process, and as you can see, we still came up with quite a few bills that are on, with quite a few, 16 items in the Medicaid omnibus. So it's a great process. People learn a lot, and we're really building our bench. We want to make sure that we have enough people that understand a very complicated program, and will be able to work with advocates on these issues. Do you want to?
Just a couple of things that I believe were mentioned. The DUA into the early groups are really important. I think that's we work with HFS on that to address this issue of the health disparity of minority women and health outcomes of minority women in terms of childbirth. I think we all know the discrepancies in maternal death rates that exist there. So that was a very important piece that was in this skinny but effective bill. And then the other interesting piece in there is the requirement that HFS produce standardized and transparent rules for the MCOs going forward. For 10 years, we've had this friction between the payers and providers, and every year we end up with legislation. And if you think about the Medicaid program, it's one health benefit plan, right? And it should be exactly the same across all of the MCOs. But one service under the plan may be denied by one MCO and granted by another. So 2 years ago, we passed legislation, we passed legislation requiring HFS to look at this issue of standardization, prior authorization, and transparency so that our providers know what is expected to be approved, if it's not approved. So yeah, a skinny bill, a lean bill as you call it, but an effective bill that I think is going to really help reduce this friction between the plans and providers, where we're not going to the General Assembly every year arguing over denials and delays.
Definitely. John, was there anything in the omnibus this year that directly affects behavioral health?
No, off the top of my head, I can't.
No, there you go. Makes it quick and easy there. Well, John, I don't want you to not have much, but I do want to go to you and just kind of, switch gears. Obviously, we've hit on some of the high, big pieces of legislation we had a lot of notice. But just kind of from your perspective, what are some of the proposals this year that are maybe flying under the radar, that maybe are going to have a bigger impact than some of the attention that they'd be getting?
Yeah, I mentioned a few of the measures that did not pass that we're hopeful that we can get through across the finish line next session or what have you. I think, there's, if I can kind of expand the answer to go beyond just legislation, we're very grateful for the partnership that we have with our leadership in the House and the Senate and in the administration in dealing with the funding and how we can ensure adequate behavioral health services for Illinoisans. So we've been sort of creative in how we approach that. And one of the biggest opportunities for the field that's come along and once in a lifetime probably is the use of the opioid settlement funds in order to address the needs, obviously first and foremost for those most impacted by the opioid epidemic, but then as an opportunity to really restructure or reform and firmly establish the treatment and service system. So we've been working with the department in trying to come up with ideas to proactively address what we're expecting to come from Washington. And one of the areas that we did this past year, I think succeeded in among many proposals that have been reviewed and approved by the Opioid Remediation Advisory Board, is to allocate certain opioid settlement funds for the field to ensure that if there are cuts, if there's not sufficient budget to meet the needs of the communities, that there is funding available for those services. So I think we continue this partnership and try to move forward with that.
Definitely. Garth, I want to go over to you. Obviously, PBMs was the main focus for your members, but is there anything else that maybe is also going to have a pretty big impact on the pharmacy side that maybe isn't getting a lot of attention yet?
There's at least two measures I can think of, in addition to the prior authorization reform, that's going to have a huge impact on access. One of the other provisions there was a modification to the scope of practice for reproductive health and opening up additional contraceptive methods that pharmacists can work under the standing order to provide, including emergency contraception. So that's going to be a huge addition of opportunity there. In addition to the eye drop program or the program that allows for medications that are unused to be able to be pushed to free clinics, that's going to be helpful because there's been a lot of that program got passed a couple of years ago. It just needed a little bit of a suggestive push, and hopefully this year we've got that with the legislation. But I do want to go back really quickly to one thing. One thing I didn't forget to talk about earlier. I do want to thank Senator Taylor and Representative Manley for their leadership on this PBM bill. That bill, with the help of the staff of the governor's office, with Emily Miller and Caitlin and Jacob, none of this would have happened without them. And then Peter Taylor and Leader Manley just pushing this to the floor and pushing it across the line and making sure that everyone was heard on all sides through that whole process. That's what got that to success. But there's still a lot of provisions that need to be discussed as we go forward, whether it's 340B or even looking at how we're going to need to address issues coming from Washington. Right now, a lot of my members are concerned a lot about immunization practices and actions that have changed with the CDC and how to address that. So a lot of us that work with the General Assembly and the Governor's Office soon.
Yeah, definitely. And Dave, I actually want to go to you and, Garth had mentioned it, just kind of talk about some stuff that maybe didn't make it across the finish line this year. I know one of the things that was IHA's main priority was the 340B reform. It passed the Senate. It was not called in the House before adjournment. And I just, first of all, just how exactly will your members be affected without the passage? And then also just kind of what's next in this effort?
Yeah, so appreciate the question. So let me take a step back. This 340B issue came to the states as a result of gridlock in Congress, right, where 340B providers and the farm industry could not reach agreement on where to go forward with 340B. I wish we had some of that gridlock in place today in Congress, but that's what brought the issue out to the states. And I think Cyrus is 17 states now. 17 states now have passed a bill that passed the Senate and passed the House Executive Committee. But it's been 2 years in the making. There's obviously opposition from pharma. So we had 2 good hearings, one in the Senate, one in the House. But the House bill, the bill that came over from the Senate came over very late in the session, at a time when Leader Dave was trying to get the budget through, and all those things were taking place at the same time. But again, we're very optimistic about it going forward. It's important because it's really a discount program, right? The drugs are required to be sold at a discount to the hospital, allows those resources to be saved and used in other places, and it's a significant revenue source for both hospitals and our FQ partners. And we've got work to do on that. We've got some conversations that we've got to hold with both those legislators that were undecided. We've also got to have conversations with pharma industry about how we go forward here. But it is a program that's been in place since the 90s. It was expanded in the Affordable Care Act. Some of that expansion has been criticized by the pharma industry, even though they supported the bill. But there's more conversations that have to take place, but it's really critical. If you think about the revenue that we're expected to lose from the Medicaid cuts that are coming down, I mean, the House version was $880 billion. We're not going to see the score from the Senate text probably until after they vote for it, but it's got to be over $1 trillion. It's got to be. And that means the loss of tens of thousands of jobs in this state, patient access. If you think our EDs are full today, we're the 5th longest wait times in our EDs right now. 3 hours is the average wait time in an emergency department in a hospital in Illinois right now. So these resources, and I mentioned this earlier, the 2 biggest drivers coming out of COVID are the cost of prescription drugs for hospitals. We're one of the biggest purchasers of prescription drugs in the country, and the labor costs. So you're not going to roll those back, and you're going to have resources to address that. So we're going to continue to have those conversations with the leadership. As I said, it's been 2 years. This is the first year we're going to get hearings in both chambers. The bill came over very late. Anna Moeller, Chairwoman Moeller, has done a terrific job explaining a very complicated issue. We've met with various caucuses in the House, the Women's Caucus, the African American Caucus, the Moderate Caucus. So those talks will continue. It's very critical that this get done.
Definitely. The Leader Dave, I'm going to go to you. Obviously, you guys are handful as a budgeteer and all the other responsibilities, but one of the main pushes that you had near the end of the session was legislation that would create a pathway for Illinoisans near death to medically end their own lives. Well, narrowly passed the House. It was not called to the Senate before adjournment. Just what's next in this effort, and what hurdles remain?
Sure, thank you for the question. I think that we worked, very hard in the House to get this passed. It's even though we haven't had a direct legislation that we moved in the last few years, we've been having many conversations with all the advocacy groups around it, and I think that the debate that we had on it was really very good. I think that it allowed everyone to express their views on the issue, and as you know, the vote came up. I think we had about 63 votes on it. So the Senate had been also working on this bill during session, and I just at a certain point I felt like I couldn't wait any longer for the Senate bill. So I did. I grabbed a Senate bill that was already in the House on third reading, and unfortunately, we can't change titles, so the title of the bill is something about sanitation. But I think anyway, people understood what was going on. So it's now in the Senate, and it only needs to be concurred. So I feel like we have another whole year to do that. I do believe we have the votes there, and we just kind of ran out of time. So I'm hoping that we can do the bill early next session, because as you know, too many bills we ran out of time with. I mean,
So it won't go forward in the veto session?
no.
They
No,
have
the
a
veto
bill, they
session.
don't bother who, will
I'm
not-
so sorry. I know.
But they have it in 12 other jurisdictions, so it seems like we're.
They do. They do. They have it in 11 states and DC. As you know, we had, the Cardinal was calling people, not the Cardinal, the Cardinal was actually calling people. He met with the Speaker, he met with the Senate President, he was very, very much opposed to the bill. So it makes it harder in the state. We also had some members of the disability community that were against it. My view is that, Margaret Bristow was against it, and she was the leader of Access Living, and after she's passed, they just won't even talk about it. They're just, we're doing what Marco wanted us to do. So there's not even any negotiation with them at this point. So, no, veto session, you need 71 votes. We need a supermajority. We didn't have it in the House. I don't think they have it in the Senate. And it's on concurrence, so we can't change the effective date in order to go back to getting just a majority. So it'll move.
Okay.
It'll move.
Okay, wonderful. We have about 7 minutes left, so I do want to see if there's any questions from the audience. So if you have a question, please just raise your hand. I'll call on you as I see you. If you can, just please let us know who you're directing your question toward.
I do want to mention.
Please.
Just some of the
Yeah,
things,
so go ahead.
some of the things we did in the budget to protect us from what we expect to happen at the federal level. So in terms of the budget, so there were 3 things that we were able to agree on. One of them was changing the expanding the emergency fund transfer authority for the comptroller. So normally, and this is to be able to cover bills that are sitting there and that we have to pay. Otherwise, we'll bounce payroll. And normally, you have to pay it back in 7 days, and we're going to be giving her 30 days. So we're just extending the time. Also, with the treasurer, we're expanding the treasurer's investment borrowing authority as well. Right now, he's allowed additional. We're adding additional funds to receive transfers to avoid high interest costs. Because he can't borrow it internally, he has to borrow the money externally. And then, because we are expecting shortfalls, we're concerned about it. And then the third thing that we did was we created the Bridge Fund, which we used transfers from some of the other state funds in our budget. We have general revenue, and then we have other state funds, which actually equal or even more than the amount of money that's in the general revenue fund. And some of these funds have excessive funds in them, and they also refill themselves every year. So we borrow from those kinds of funds. Actually, we took from those kinds of funds, and we set up this bridge fund that can be used for emergencies, and that has anywhere between 100. I think we did like about 130 million this year. So those are 3 ways that we tried to help our budget be stable in case of drastic measures coming down from the feds. Okay, sorry. Questions?
Yeah, any questions from the audience? Oh, yes.
Hi, everybody. You can see me, Heather O'Donnell with Threshold. It's not a question, but I just got to shout it out because Leader Gable has been a little bit of an advisor to a bill that Threshold has been championing with the behavioral health sector at large. It's not a Medicaid bill, it's a private insurance bill, really addressing the disparity in reimbursement between behavioral health and med surg across the commercial insurance sector. really drives very narrow networks for behavioral health, and it's why insurance is often meaningless for people with behavioral health benefits. So it's just a long-term advocacy effort that we're working on with some of our trades and hundreds of people across the private practice sector. So just something to flag for everybody. But thank you for all your advocacy. And so I just wanted to give that a shout out.
Great. And Jen, obviously, I wonder if you may want to discuss that a little bit. That's on my list of questions here. We'll get to it. And it was obviously something that did not pass in the Senate or in the chamber this year. Obviously, the insurers raised concerns about putting minimum reimbursement rates in statute. They said that's unprecedented. That's not something that is done. So I wonder if you just kind of talk about the efforts and kind of what's next on the reimbursement rate for.
Well, I think, Heather's obviously the expert on the bill itself. I would say that we will see if Heather is still involved in the bill moving forward. Okay, good. I 100% agree with the rationale, the logic. The concept is brilliant. Particularly in the mental health space, you are dealing with very narrow networks. A lot of out-of-network services are provided because of low reimbursement rates in the commercial field. So I think it would be a bonanza for patients to be able to find and utilize the behavioral health care provider that they want to. And I think that bill would definitely support those efforts.
John, you have a pretty loud voice. I think you carry pretty well. Great. I think we have just about 2 minutes left, so I do want to close out with one final question, and we'll go to each of our panelists. The mic's over on that side, so we'll let Gar start us off, and we'll go down the row. But just kind of about 30 seconds or less, just kind of what's going to be your main healthcare focus as we head into the summer, into the fall? Just kind of what are you looking for?
It's just going to be continuing the fight for implementation and enforcement of the provisions of PPO reform. And then, as we've seen with Washington, it's basically going to be the fight for scientific integrity and how that's going to impact our patients and put providers in some very precarious situations going forward.
John, what about you? What are some things you're keeping your eye on here in the summer and into the fall?
Yeah, definitely continuing with the efforts surrounding the bill that Heather mentioned, as well as the expansion to include SUD outpatient and the prior authorization prohibition. There were other efforts as well that I'm not going to get into for time's sake, but just to echo the comments about everything coming down from Washington and how we can address that, and just working in partnership with Leader Gable and other behavioral health champions, as well as the administration, on trying to find creative ways to address what we assume is going to be a very difficult budget year next year.
Dave, what about you?
State in Washington, $20 billion comes to the Medicaid program through the federal government, and you're looking at 20% decreases in funding under some of these proposals, and have a devastating impact on Medicaid and the safety net system in the state. And we have to let our policymakers know the consequences, both to patients and to the services and to the jobs. They're going to be lost to the economy if this thing goes through as it is written.
Absolutely. And Leader Gable, so I'll let you close us out. What are you focused on?
Sure. In terms of healthcare, I will be working this summer with senators to make sure that we have the votes to pass medical aid and dying. It's time in Illinois, and we need to get that done.
Great. Well, we can keep going, but we'll end the discussion with that. Thank everyone for coming out today. At least did for the end. And thanks so much for coming out today. With that, I'm going to wish you all a great rest of your day. If I don't see you, have a great rest of your summer.
Thank you, Ryan.
Yeah, of course. Thanks for coming out.
Good job.
Yeah.
Wonderful, yeah.
We were just waiting to get that.
Absolutely, yeah.